syndrome. So this disorder is toxic encephalopathy, and usually it is connected with other organs that are involved. Um, and usually it's fatty changes of the liver. So the onset has to do with profuse, effortless vomiting. I can't imagine vomiting has ever been effortless, but different from intracranial pressure where it's very forceful. This is effortless vomiting. And lethargy, there's a quick progression to neurological impairment. In other words, they don't think correctly, they're confused. They may have sort of delirium. Sometimes they will have seizures, and this too can cause coma. Ultimately, it does lead to increased cranial pressure, and it can lead to herniation and death. Not everyone dies from this, not all children will, but it can be very serious, especially if not caught early on. So it's characterized by fever, again, impaired consciousness, and the liver function. The liver's not functioning properly. We don't really know why this happens, although when you give kids aspirin, they have the potential to have Reye's syndrome. Most cases will follow a common viral illness, and the reason kids are getting aspirin is because they have influenza or chickenpox. Now, we don't see chickenpox in the same way that we used to, although that's starting to come back as well. But for instance, back when we were kids, which was, as you know, a long time ago, there was no varicella vaccination. So kids would get the chicken pox. And we had aspirin. We didn't have ibuprofen. Tylenol was there, but aspirin mostly. So this was a little bit more common then. But that's the reason that kids are getting aspirin. So when you have parents and you're teaching them about things to give kids for fevers, always teach them to give the Tylenol and ibuprofen and not aspirin. So usually it follows some sort of viral illness, because with viral illnesses, as you know, your temperature is much higher. And if the temperature becomes too high, children can have seizures. So it was always important to bring that temperature down. Let's see. I think that's all I want to say about Reye's. Let's move on. Diagnostic evaluations. So they will do a liver biopsy, and that is the only way to do a definitive diagnosis. There's staging criteria based on the liver dysfunction and the neurological signs. Also, it is based on the coma and where they are in that Glasgow scale. So the most important part of successful management for this is that we have early diagnosis. Excuse me. So with early diagnosis, we can have very aggressive care for these kids. That's the best way to get recovery and a good outcome. This can be very rapid in progression to a coma and high ammonia concentration. Those are the more serious diagnosis or prognosis. If they have a really high ammonia concentration because of the liver damage, they don't have as good of an outcome. It's a much poorer outcome. Cerebral edema with increased ICP, that is the most immediate threat to life because you can have the herniation of the brain. So despite how bad this is, if we catch it early and can do aggressive therapy, these kids will recover. So let's talk a little bit about seizure disorders. So these are caused by neural discharges or synapsing to your neurons, or not synapsing, that's connections. But when the nerves are overly active and very busy in the brain, those neurons that connect all of that activity becomes incredibly active. It is actually defined as a transient occurrence of signs or symptoms due to abnormal, excessive, and synchronous neural activity in the brain. And this will cause seizures. Now, in adults, seizures are not always considered a neurological disorder. It's usually caused from something else. But in children, it is definitely considered an actual pediatric neurological disorder. And kids are actually diagnosed with seizure disorders. The manifestation of these seizures really depends on where in the brain the activity is happening. It can originate in multiple different places, and there are lots of different types of seizures. So there are focal seizures, there are seizures that grand mal seizures, there are epidimal seizures. There's lots of different types of seizures. And this changes, when these happen, it changes what the child is doing. I remember in nursing school, we had a student, and she was taking notes in class, and she would get very focused. We all thought she was just paying attention because she was still writing in her notebook. But when you looked at her notebook, she would have words and sentences, outlines, whatever she was writing, and then scribble lines. There'd be several scribble lines. So even though she was having a focal seizure, she was still moving her hand. So each seizure will act a little bit differently. In infants, when they have the seizures, sometimes they will do bicycle movements. So when they're laying on their back, their little legs and their hands will go like they're riding a bicycle. That's very common for infants. So they're all a little bit different. The symptoms are usually due to an underlying disease process, but not always. Okay. So one of the diagnoses that you will see is epilepsy. This is when a child has 2 or more seizures that did not come from like a high fever or a head trauma, something like that. If they're unprovoked, as they call them, the child is diagnosed with epilepsy. There are lots of pathological problems or processes in the brain that cause this problem. And the optimal treatment really is to treat it, to discover it, and then they will try and determine the cause. Depending on what the cause is, they may be able to get rid of the cause, but not always. Very often, they will have epilepsy for a good share of their life. So let's talk about those causes. So acute symptomatic head trauma, meningitis, sometimes birth problems will also cause seizures. Children who have CP, they will have seizures. And I think that you talk about that in neuromuscular. Sometimes prior to brain injury, there's a bit of a stroke. Children will even have stroke in utero. There have been some children before they're born, they will have a stroke. So sometimes that has to do with aneurysms and pressure differently because of cardiac problems. But it can also be caused by increased cranial pressure after they're born as well as before. So cryptogenic seizures, they really don't have a clear cause. A lot of this is all idiopathic. We don't really know why kids get seizures, but there are kids that will be epileptic out there. So classifications, let's talk a little bit about each type. So partial seizure is very local and has a small location in the brain, and it will cause problems very specifically in different parts of the body, depending on where it's located in the brain. Generalized involves both hemispheres. So very often this will be your grand mal seizures. And then most seizures are really unclassified, sort of like focal seizures are somewhat unclassified. How we manage these, the goal is really to control the seizures and reduce that frequency and severity. We want to give this child as normal a life as possible. So when a child has a seizure in front of you, you want to be sure you document a very detailed description of what happened, what the child was doing beforehand, how the seizure started, how did it, what time the seizure started, how did the seizure progress, how long did it last, when did it end, and how did the child feel afterwards? Did the child have incontinence of any kind, either urine or bowel? And did they stop breathing? Usually you need to put them in a protective position. You don't want to hold them down. You don't want to put anything in their mouth, lay them on their side, so if they vomit or drool, they will not aspirate that. In that way, because of the description, sometimes we can discover the cause and correct it. Most often, we give these kids medications. There's several different ones. There's some newer ones out now than used to be. Phenobarb is probably the most common and oldest medication, but that makes kids really tired and causes other problems. Plus, it can be somewhat addictive. So they don't always use that. So let me see what else I have in my notes here. You want to ask questions of the child. Sometimes they have seizures at specific times, early morning, while they're sleeping. Sometimes it doesn't matter. I have a friend whose daughter has seizures, and she has them at all times during the day. However, one of the auras that she has is she will smell Parmesan cheese, which is kind of odd, but a lot of the auras are really interesting. Kids will see colors, they'll smell something, they'll see something, see halos, see lights. Sometimes they'll hear something. So ask them about that. What did you hear or do or see or smell before the seizure started? Sometimes there are activities that will bring it on. Hormones, very often hormones with girls, it could be their menstrual cycle will bring it on. And then they'll have it as adults because it's connected to hormones. Other times, not so much. It can also include fever. Small children in particular get very high fevers, can seize. Adults who have very high fevers can seize as well, but it's more apt to happen in children because they will get a high fever much quicker. Infection, head trauma, anxiety, fatigue, and sleep deprivation. Again, my friend's daughter, if she doesn't sleep, she will for sure have a seizure at some point during the day. Alcohol and, like I said, certain types of activity. Another thing we found, my friend's daughter, she has multiple issues, so it's not just the seizures, but she was playing this game where blocks were blinking and you had to do certain things with the blocks when they were blinking. And it was the blinking that caused a seizure for her. Sometimes you'll notice you'll go into a ride. At Disney, there are a couple rides. I don't know if they still have them because they're kind of old, but they would have a lot of flashing lights. And they will say, if you have seizures, you shouldn't be on that particular ride. So there's lots of things that can cause seizures, and it's good to ask all of those questions. They will usually start children on a medication at the lowest dose and gradually increase until the seizures are controlled. And sometimes they will add a second drug. It really depends on how they do with the first one. Okay. Febrile seizures. These are very transient for children and more common in children than adults. They can affect 2 to 5% of children, and most often, like I said, when they're young. 6 months to 3 years is the most common age group. However, they can still have them later in life. They're more frequent in boys. Everything seems to be more frequent in boys. They don't really know why, but it's more common in viral than bacterial. And I think that's true if you think about it. Viral infections usually have a much higher temperature than bacterial infections. And bacterial infections we can control fairly quickly. We can give antibiotics, and within 24 hours that starts to work. But viral infections are not like that. It's much more difficult to control the temperature, so it's much more common for children to have seizures with a viral infection. Okay, we're going to switch it up here a little bit and talk about hydrocephalus. So this is something that is most common with small children, infants and small children, but can happen later in life as well. It is truly an imbalance in the production and absorption of the cerebral spinal fluid. So remember I said it's 10% of what's in the brain is the cerebral spinal fluid. So if that balance increases, these kids can get hydrocephalus. Usually it's because the absorption is not happening, but yet the body's still producing the fluid, and an obstruction happens. And so we'll talk about some of those problems. So here is a picture of hydrocephalus. You can see it most frequently happens in the ventricles. And then, sorry, Max is not happy about something, so he's a little bark going on there. So it most often happens in the ventricles, as I said, and there are 4 ventricles. When you talk about hydrocephalus, especially someplace like the NICU or with these small children in the peds ICU, they will grade the hydrocephalus 1 through 4. And the worse it is, the higher the number. And the worse it is, the more it will be down into the 4th ventricle. So it can be very progressive, going from the ventricles, the 2 ventricles at the top, down to the 3rd, down to that tube called the sylvius, and then down to the 4th ventricle. When the 4th ventricle starts to expand because of the hydrocephalus, that is considered a grade 4, and as you can see, it really touches against the brainstem. Okay, let's go on to the next. This can be caused by a couple of different defects. Usually they're apparent really early in infancy. The most common causes, obviously, neoplasms, infection, and trauma. But you see it most often associated with myelomeningocele. Now, we don't see spina bifida at any level as often as we used to. There was a time when it was not known that pregnant women needed a higher level of folic acid. So now that we know that, we don't see myelomeningoceles in the same way that we used to. So you don't see as much hydrocephalus for that specific reason. But when it occurs before the fusion of the cranial sutures, it can really cause an enlargement of the skull. And the ventricles will dilate, the skull will expand, the sutures will separate, the fontanelles will bulge, and it can become a really big problem. Now, before a child turns 12, depending on how bad the pressure is, those sutures can open back up. But it has to be pretty bad for that to happen. So I have seen these kids' heads get really, really large. This is when they have that sundowning that we talked about, where you only see half of their eye, half the pupil, half of the iris, and you see the large veins when they have hydrocephalus, and their heads get very large. There is no way for them to be able to hold their head, and you have to handle these children very carefully. I have seen their head circumference increase by 100% or more. And it's really sad when you see this. The parents struggle with it so much when these kids' heads get that big. Usually when their heads are that large, they're at a grade 4, and they don't do very well. Usually when it gets to a grade 4, these children will not grow up to ride bikes, go to school, get married, have their own children. They will pretty much be full care for their lives. Okay, now we can handle hydrocephalus. So if we can get a handle on it, those things won't happen. Once we start handling hydrocephalus and the head goes down, we can have really good prognosis. So in kids like the myelomeningocele kids, spina bifida kids, we know to look for this, and we can usually treat those complications very early on and get a good grasp of this, and we don't have such large problems. So we want to get a handle on that really quickly. Most often it's surgical. They will put in a shunt. I'm going to go to the next page. So this is the shunt that they have always put in the past. They have several new ones now, and I'll talk about those in a minute. But this particular shunt takes the extra fluid and puts it down into the abdominal cavity under the diaphragm. Sorry, someone is IMing me. Let me just say that I'm busy. Okay, Sorry for the distraction, guys. Okay, so I probably should change my, okay. I'm so sorry for the distraction. Okay, here we go. So this particular shunt takes that fluid and puts it down in the abdomen where it can be absorbed more readily. So that's probably one of the most common things you will see if we can't grasp a hold of all that fluid in there. There are some other things that they do now. Sometimes they put in where you see this up here, instead of putting in this tube that goes all the way down, they'll put in a little, sort of like a collecting bin, so to speak, or bowl or object that collects the fluid, and they can go into it multiple times, sort of like a port where you can put an IV in multiple times. It's the same type of thing. And they'll take a needle and they'll go in and they'll drain just that little piece. And that will help also. So that's one other thing. There is another more complicated one that I'm not going to go into. It has to do with leveling and on and off switches, and it's incredibly complicated. But I will let, if you decide to go into pediatrics, they will teach you how to do that, and I'll let that go for that time. Okay, let's go to the next slide. So sometimes these shunts will get infected. This is the biggest problem, and it can cause an obstruction. So the cardinal sign for this is a headache. Now, can these kids tell you they have a headache? Sometimes down the road they can, but usually they cannot. So again, you have to go back to those level of consciousness changes with ICP. Their level of consciousness. Are they irritable? Are they feeding poorly? All of those things to go back to, is potentially their shunt obstructed or infected. So the biggest risk is 1 to 2 months after it's placed. And just to make another note, sometimes these kids need to have another shunt, because if we go back and look at this, as the child grows, what's going to happen? This is going to slowly but surely pull out of the abdomen. So there are times when a child will need a second shunt or a third shunt, but very often they don't need another one. Sometimes it will just, it'll go out of place and they'll never need it again. It depends on the child. So infections, let's go back to that. So septicemia, bacterial endocarditis, wound infection, shunt nephritis, and meningitis. All of these things can cause a problem with an obstruction for these kids. These kids will be on massive doses of antibiotics. They will pull the shunt, and eventually they may have to put it back in. But these are some of the problems that can be caused by a shunt. Okay, well, that is the end of this particular audio. So thank you for your attention. If you have any questions, feel free to reach out to myself, Dr. Moritz, or your instructor for any of those questions.